Um, we're going to go ahead and start. There's a couple people coming in a little later, but we do have a quorum, so we'll go ahead and start the meeting. Welcome to the regular meeting of the Governing Board of the Inland Empire Health Plan and IEHP Health Access. Today is November 13, 2025 at 9:02 a.m. I'm going to go ahead and call the meeting to order for the IEHP Health Access Governing Board. The Pledge of Allegiance, if you could please stand, put your right hand over your heart, and begin.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Thank you, everyone, and good morning. Madam Clerk, if we could do roll call, please.
Certainly. Good morning. Yes. Chair Gutierrez. We do have a confirmed absence for Vice Chair Hagman today. Member Spiegel?
I do want it noted in the minutes that I was the first one here today. I want Mr. Hagman to know that. Thank you.
Noted. Member Armendariz.
I want to note it that I was the last one here today.
All right. Member Anderson.
Here.
Member Williams.
Here.
All right. And we do have Eileen Zorn, not here at the moment. Thank you, sir.
Perfect. All right, any changes to the agenda?
No, sir.
No? Okay, and I believe we do have one public comment?
Not on this agenda
on matters
for
on-
IEHP for the next meeting.
Okay, got
Not
it,
for health
okay.
access. Thank you, sir.
Okay, perfect. And then any conflict of interest from any of my colleagues? No, okay, no, okay. And then the following meeting minutes and consent agenda can be taken as one. So unless the board would like to pull the item, I'm going to ask that we recommend one motion on the following: the meeting minutes from August 11, 2025, and consent item 1.
Move to approve.
A motion made by Member Anderson,
I'll second.
second by Member Armendariz. Okay, all those in favor say aye.
Right.
Aye.
Okay, great, no nays, so motion carries. All right. So that goes to now our policy agenda and status report,
Correct.
Yeah.
Yes.
which is a report from Dr. Jun.
Governing Board, can you all hear me? Oh, I can hear myself. Great. Before we jump into the presentation, I just kind of wanted to refresh everyone's memory on, what health access is and what it does. And if you recall, back in July of 2024, we really started our work specifically around our enhanced care management provider delivery through health access. And what this work is really focusing in on is a function focusing on people with complex health and social needs. So again, from a health access perspective, enhanced care management, or ECM, is really about meeting our members face-to-face in the community, in the place of their choice. So for example, this could be in the community setting or in their home. And the team does this to really provide support and advocacy beyond the traditional context. So for example, attending doctor appointments with members, and each member has an assigned care manager through our ECM health access work, as well as a care management team to follow up on member needs. And the frequency of interaction with our members is intense in the right type of way. And sometimes this can take place once or more a week, depending on the need. So today we'll share with you the financials for health access. But before we dive in and I pass it over to Vicki, just a big kudos to Dr. Wada, who had essentially helped lead this effort up until recently, and Anna Edwards for really driving the work with her and her teams on a day-to-day basis. So just want to send my kudos to those leaders. So with that, I will pass it over to Vicki.
Good morning, members of the board. We're going to go ahead and share with you the financials that we have for the health access. Annette? Okay, thank you. Okay, as you can see for our September financials for health access, we have a surplus for the month in our actuals. We have about $200,000. So it's right on target and where we wanted it to be. For our year to date, we have about $3.3 million surplus in there. As you can note, in the month of September, it was a little bit lower than what we initially budgeted. We do believe that you'll see in future months that some of that will be picked up, because there's a lot of timing differences on some of these things. So we still believe that we're pretty much right on target where we want to be. I'm not sure how much information you guys do know about how the revenue is actually produced for ECM or through the health access for this particular area. So just to give a little background on that, when they earn their revenue is based on the members that we have that are engaged in this program. Once they're engaged, you have one engagement, you get actually payment for 3 months. For one engagement. So for every 90 days, we want to make sure that we're engaged. And along with all of our other providers, as long as they're engaged, then they're actually getting their capitation each month. The other way that they actually do receive revenue is through outreach. And that's actually done through, it's a small dollar amount, but there's a lot of work that goes through it. They submit through claims, they get reimbursed through that as well. Okay. If we can go to the next slide, please. This one here kind of just shows you what our current month is to prior months. And as you can see, the prior month was a little bit lower, but we actually attribute that to a lot of the timing differences, because it does take time for them to put their claims in and so forth. So we have no concerns there. Next. And again, you can kind of see how it varies. It varies slightly each month, but again, on our year-to-date basis, we're actually doing very well in what we anticipated. Okay. And then our balance sheet. As you can see on our balance sheet, we do still have a pretty healthy bottom line for them as well. So right now, their net position at this point is a little over $6 million. So they're solid for today. Okay, last one. And cash flow. Again, you could see that they still have a healthy bottom line for this group. I made it short and sweet.
Great, no, love it.
And maybe just to kind of maybe close this out again, just a big thanks again to all the ECM team members under Health Access. As Vicki had mentioned, one of the big things that we're focusing on is both engagement and enrollment, because we want to make sure that members are appropriately receiving these ECM services through Health Access. And I'd just like to highlight, a few things, or maybe several things that are taking place in the engagement and the enrollment area, just because the work that the team is doing, I would say, behind the scenes is really great work to advance and move forward in these areas. So some of the engagement improvement strategies that Anna Edwards and her teams are focusing in on is also making sure that we have a proactive data review process so that we're better able to identify members who need or may not need these services, again, in an appropriate manner. There's been a lot of analytics in terms of what variance we might be seeing in enrollment and why. And there's also been a lot of accountability within the leadership teams, within the ECM teams themselves, to ensure that everything is appropriately documented and that the engagement is happening in the way that we would expect from an ECM provider. So again, that rigor and that standard is top of mind for the team. From an enrollment improvement strategy, just a few items to call out is that, again, there's been a lot of work on leveraging new concepts, new techniques in the form of a pilot to, for example, use coordinators that are more dedicated to enrollment, outreach, and screening to potentially shift other team members to focus on other needs within their caseload. And I'm just really appreciative of the team making sure that they're focusing in on that. And they're also implementing a new sort of outreach outcome report so that, again, there's visibility and transparency into what all our team members and care teams are working on. So again, just a few highlights. And again, we'd be happy to bring back more information, but I think that concludes this first section. Thank you.
All right. Thank you, Dr. Chun. For the presentation, any questions from my colleagues? All right, thank you so much. This is just receive and file. So we'll go to comments from the public on matters not on the agenda.
No comments, sir.
Okay, seeing that there's no comments, we'll move on to board member comments. Any comments on, no? Okay. And there's no closed session. So we'll go ahead and adjourn this Health Access Board meeting to Monday, January 12, 2025. I'm going to go ahead and now call,
I'm sorry, I'd like to correct, Monday, January 12th, 2026. I apologize
Oh,
if that was
okay.
not listed correctly, sir.
oh, thank you. Okay, so January 2026. Wait, January 26, 2026.
January 12th,
Oh,
2026.
okay. Oh, okay, did I say something else? Okay.
You said 2025.
Okay, sorry, okay.
That's okay,
All right,
habits.
okay, all right. We'll move on. Okay.
We are adjourned.
Okay. So we've adjourned that meeting. Now we're going to go into the main meeting. So I'm going to go ahead and call the meeting to order on November 13, 2025, our IHP Governing Board meeting to order. We're going to skip, if everyone's okay with the pledge, since we already just did that. Madam Clerk, roll call? Or
Yes, sir.
we're seeing everybody
Well,
here.
we do have Member Zorn with us
Oh,
now,
yes,
so the
yes.
record will reflect that. Thank you, Member Zorn. Welcome.
All right, perfect. Any changes to the agenda? Seeing that there's none, right, Madam Clerk?
Correct.
Okay. And public comments on matters on the agenda?
Yes, sir, we do have a public comment, and I'd like to ask that S. Wakar Nakvi please come to the podium.
Okay. And you will have 3 minutes, sir.
Good morning.
Good morning.
Member of the board and IHP representatives, thank you for the opportunity to speak. Myself is Wakar Nakwi. I'm CEO of Yamsol, a software production company. I participated in a recent pilot program intended to evaluate transport management system of IEHP. My team invested significant time and resources over the past several weeks to assist IEHP in identifying a stable, cost-effective, and scalable platform. At the conclusion of the pilot, we submitted a detailed diagnostic report summarizing the technical results of the integrations, including system performance, functionality, and compliance with IEHP requirements. To date, we have not received any acknowledgement or feedback regarding that report. From our direct experience, the Kinetic platform successfully completed the integrations and demonstrated reliable functionality during testing. In contrast, MediDrive system was unable to complete integration successfully. Given these objective findings, the recent announcement that MediDrive was awarded the contract has generated considerable confusion among transportation providers who participated in and supported the pilot program. Many of us were under the impression that the purpose of the process was to select the vendor that performed most effectively and efficiently during the pilot evaluations. In light of that, I respectfully request clarification on 3 points. Number one, was the pilot performance data, including our diagnostic report, reviewed and considered prior to final selection? Number two, what specific evaluation criteria and weighting were used in determining the outcome? And number three, what was the rationale of selecting a vendor whose system did not meet the integration benchmark established by IEHP? These questions are raised in the spirit of transparency and shared accountability. As you know, the provider community still remember the disruption caused by prior unsuccessful software implementation. Many of us participated in this pilot precisely to help IEHP avoid a repeat of those issues. I respectfully ask that this board review the procurement record, consider the objective technical data, and provide a clear explanation to the providers and members who will ultimately be affected by this decision. Thank you for your time and consideration. Wakar Yamso.
Thank you, sir. Thank you.
Thank you. I appreciate that.
And just so you know, with public comments, we can't respond too long because of it's not agendized, but I would like to ask staff to
I'm
just
sorry,
follow
sir.
up.
This is agendized. This is
Oh, it
item
is?
23.
Oh,
yes.
okay, okay. Well, either way, you know, if we can just follow up with the gentleman on his 3
Noted, sir.
issues. Okay. All right, so we'll go ahead and move on. Okay, I'm sorry. All right. Okay. So any conflict of interest for the record, we'd just like to note that as members of the Riverside County Board of Supervisors, neither I nor my colleague Supervisor Spiegel has any financial interest in consent item 28 that would constitute a disqualifying conflict of interest. Our vote on this item is in our capacity as IHP governing board members. I just wanted to read that into the record. All right, so unless the board would like to pull an item from the consent agenda for further discussion, I'd like to recommend that we vote in one motion the meeting minutes from October 14, 2025, and consent items 1 through 28.
I'd like to pull 23.
Okay,
I'm sorry, can you repeat that?
23.
23.
We're going to pull that for further discussion?
Yes.
Thank you.
Okay, so item pulled 23. Is everyone okay with just a motion to approve everything except item 23?
Yes.
Yeah, I'll make the
So
motion.
moved.
Motion by Member Zorn.
Member Anderson. He did the motion, and second, Member
Yes.
Zorn?
Okay,
Love
that's
the
fine.
second.
Yeah, that's fine.
Yeah,
Okay, so Anderson and then Zorn.
Thank you.
sounds good.
We get it done one way or another.
Okay.
Absolutely.
All right, all those in favor say aye.
Aye.
All right, awesome. Okay, we're going to go ahead and go straight to item 23. We can hear a report from staff.
Sure, Mr. Chair. I'm going to ask our Vice President of Provider Experience, Mike Grant, who led this RFP, to come forward and share more details about this project. So, Mike? Hi, good morning, Mike.
Good morning.
You can give us a report, or well, actually, I'll turn it over to Supervisor Spiegel if there's any questions you have.
No, just,
Yeah, I can speak a little bit to the RFP that was conducted, and it was conducted over several months to replace a system that we had in place earlier this year that did not work out well for us. So we went through a quick and full RFP looking for a management system that would help our transportation business. We have a completely manual process right now, so we needed something that would help us improve the member experience, automate our transportation, and improve efficiencies across the board. So we went through that entire process. We went through a very lengthy demonstration process, several meetings with our two finalists that we had as bidders. We did go through a demo process, and as part of the evaluation that we used. The demo itself, we had some issues with our transportation provider. It's a long story with our system, and we worked through it all. We evaluated both systems that we were looking at. We did a fairly deep diagnostic on all of the attributes that we looked at. It's in the board report related to the technology functions as well as just the maturity of the two systems, and decided on MetaDrive as our selection based on all the criteria that we were looking at. And we had several, like I said, iterations with both, and found that MetaDrive is definitely the choice for us as we go forward. Due to its technical capability, it's an organization that's been in existence for over 3 decades, providing transportation service systems across the United States, and we're quite confident that it's what we will need to be able to take us to that next transformation in our transportation business.
just wanted to confirm there was conversation with the gentleman that came forward, and you have shared basically the same thing with them?
Yes, definitely. NEMT Platform was an organization that we asked to help participate in the kind of the demonstration pilot. It's a long story, but basically when we have a transportation provider and we picked one that we use to help have their trips loaded into this system, which then loads into the two bidders system. That's the easiest way to describe it.
Okay.
And we did that with them. We did have some issues with MetaDrive during the process, and it was basically because of our transportation provider changed some of the criteria and some of the data they were using during the live demo, which then didn't work as it transitioned into the two systems, Kinetic and MetaDrive. So with the MetaDrive one, they were on 2 different days. With the MetaDrive one, it didn't work as well because of the transportation provider changing the data from what was supposed to happen. They didn't do that with the other bidder. So we walked all through that. In the afternoon, we went through it again, and the bidder, MetaDrive, was able to show that it was successful throughout all of the transportation trips to show that it works in their system.
All right, thank you.
Thank you, sir.
Thank you.
Any further questions from my colleagues?
No.
No? Okay.
not at this point.
I'd like to entertain a motion to approve the item.
So moved.
Okay, motion made by Member Zorn.
A second.
Okay, second made by Member Supervisor Spiegel. Okay, all those in favor say aye.
Aye.
Aye. Okay, thank you.
Thank you.
Okay, we're going to move straight to policy agenda and status report on agency operations. We have our CEO with us here today, our administration. He's going to do some slides. All right.
Thank you so much, Mr. Chair and Board, and great to be with you on this Thursday, which is kind of unique for us, I know, and thank you for your patience as we were moving schedules around to make sure as many folks could be here as possible. And we're thrilled that we have, it looks like, come on the other side of the government shutdown. As you folks all know, the impact to our members and providers was quite intense, just simply because particularly what we were worried about is folks' access to food and SNAP benefits and whatnot. And so we're really, really thrilled that that's ended and that we're hoping to get back to some normalcy. I do want to give a big shout out to the team, though, that worked with so many of our food banks here locally, so many different community-based organizations to try to make sure that those folks who really were in need during this unique time had what they needed. And so a big, big thanks to our team for that. Up next, I wanted to share a quick mission moment with you. Our COO, Susie White, actually every year has such a passion and calling to support cancer awareness, and I'm really grateful that she does. Our team consistently ranks as the top named team and top company with the Susan G. Komen team, and I'm just thrilled that once again they did such an incredibly good job to make sure that there's dollars raised for that important research and to support those that are going through this journey as well as survivors. And I just wanted to say a big thanks and shout out to Susie for her great work on that front. On the next slide, you'll see our IHP monthly membership report. And I can tell you, I am just so, that's three so's if you didn't count that, three so's proud of our team and our partnership in particular with our two counties. Our actual versus forecasted membership reductions are actually one of, if not the lowest in the state of California. It's actually remarkable what the teams have been able to do with our two county partners in enrollment and eligibility. And because this is so incredibly unique, we thought it would be important for you to hear directly from our county partners and some of the work that they're doing. And so I'd love to invite our Vice President of Strategy, Thomas Pham, who oversees much of this work with enrollment and eligibility, and share a little bit more of how are we getting these kinds of results that are just incredible. So Thomas, come on up.
Good morning, Board Chair. Good morning, Board Member. Thomas Pham, VP Strategy at IHP. So this morning, it's my super honor and very proud to introduce you our partner, our great partner with San Bernardino County Department of Public Transition Assistance Department and then Riverside County Department of Public Social Service. So I would like to invite Allison, Matt, and James and your team come up here and co-present with me on Medi-Cal eligibility. And there's one request I would have, I would ask the board member for. So ask tough question for the team here because they are the super SME on eligibility. They know everything from the policy, the operation, how this works, all the change in the marketplace. So ask them tough question. They are ready, right, James and Matt and Allison? As you know that we have the partner, our partnership with the two county are super critical in ensure that our member keep the eligibility and uninsured individual enroll in the program. And as you know, we have the partnership with the county for years. But I would like to highlight, the last few years since the COVID, that the partnership gets so much stronger. So we, from sharing the data and supporting the county with the resource, and the county create special team that focus on any eligibility need from IEHP. So We always, we text each other, we can pick up the phone, and we can call, and we can get any eligibility issue resolved right on the spot. So kudos to both San Bernardino County and Riverside County. Next slide, Annette. So would like to highlight some of the partnership initiative that we are working with Bow County now. So we share the data. We share the data every month. And every month we send to the county our IEHP membership. And county sending back to us from the list that by individual member who need to renew their Medi-Cal eligibility. And we the first one in the state that doing this, and Department of Healthcare Services promote this partnership to many other counties, and they create a statewide policy that require the county to partner with health plan. But we the pioneer in this state, and appreciate the county that with the bold and courageous leadership that allow us to do data sharing. And not only the eligibility side that we share the data on our member who somehow enroll in incorrect category of aid. And you know that any system is not 100%. There always are 1% or 2% of those members that somehow not enroll in the right category of aid. And we send the list to the county, and the county able to review and place them in the right category of aid. And another bucket is newborn. So every year we send to the county about 10,000 newborn that somehow that the mom have not add the newborn to her case. So we partner with our quality department engineer and partner with our member services department that pull those data and provide those data to the county so the data can do outreach and enroll those newborn into mom's case. So we share data on demographics, so a lot of those space. So I want to give you a perspective of the volume. So on the category of aid, every year we send about 10,000 to 15,000 records to the county. And newborn, we're sending about, about 10,000 records as well. So as the result of those partnership, that we able to help our member to retain their eligibility, enroll and keep their eligibility, and also enroll in the right category of aid that generate extra, I call it revenue, because of the revenue gap between right category A versus the wrong category of A. And in terms of the revenue side, we generate about 20 million extra revenue a year with the partnership with the county. So with that, as you all know, that there's so many policy change and that will come soon, from the UAS population, the undocumented population, to the HR1. So I invite Matt will share what are the changes in the marketplace now and coming in 2026 and 2027, and how it impact the county and IEHP. So Matt and Allison, the floor is yours.
Thank you. Good morning, board. Thank you, Thomas. Allison Gonzalez, Assistant Director, Riverside County, Department of Social Services.
Good morning, Matt Daniels, Deputy Director with Riverside County DPSS.
If we could skip to the next slide.
Yes, they do proceed the image in the back, so just say next slide.
Okay.
Thank you.
So I wanted today to share with you how some of the current and upcoming changes to the Medi-Cal program will impact both eligibility and then the benefit coverage. Over the last 6 months, many of the public health emergency waivers we had in place, they were there to streamline many of our processes. They really simplified the customer experience, and those sunsetted in June. As a result, you can see here, we've had about 40% of families now having to engage in a very manual process for their annual renewals or submitting verifications. On the county side, our workloads increase with that manual process, and there's a delay in being able to process their Medi-Cal cases. In January, we're going to see some additional changes. One is the reinstatement of the property limits for determining eligibility. This will have the largest impact on our aged, blind, and disabled populations. Another big change that we are facing is come January, adults 19 and over that are undocumented, as new applicants will no longer be eligible to the full benefit kind of package that Medi-Cal has, and instead will only be eligible for emergency services and pregnancy-related services. Existing customers in that same category will keep their full benefit package. However, if they do fail to turn in those annual renewals and verifications that I had mentioned have become very manual, they lose that full benefit and will also be put into the category of restricted and emergency only. And then the additional change that we face is the loss of dental coverage for all of our Medi-Cal recipients.
Thank you. And then in January 2027, we see a number of large significant changes that will impact what we call our new adult group population. And these are citizens normally aged 19 to 64 without dependent children. There are a number of requirements that they will have to undergo to maintain their Medi-Cal coverage. One of those major requirements is the implementation of work or community engagement requirements. So it's a requirement for those individuals to either be working at a number of hours per month or be actively seeking work to keep their Medi-Cal benefits. So that's a major impact on our members as well as our counties in putting in the effort to assist those members in those work requirements. We also will be seeing for this population more frequent redeterminations. Currently, all Medi-Cal members renew once every year. This population will renew once every 6 months. So this more frequent renewal process will now put them at risk for potentially losing coverage if they have to renew more often. It also is a significant impact to our county workload. In Riverside County alone, this population of individuals is about 30 to 35% of our total Medi-Cal membership at the person level, and so it's a great workload impact for our county staff to do this essentially twice as often for these members. In addition, there will be some changes to retroactive coverage, and that's the ability to receive Medi-Cal benefits for the months prior to an application. Historically, it's always been the 3 months before you apply, you can get your Medi-Cal coverage for those prior 3 months. For this new adult group, that is changing from 3 months to the month before application. So it really does impact their ability to get coverage or payment of bills before they apply for Medi-Cal. With this retroactive coverage change, all other individuals outside of this new adult group, age 19 to 64, and citizens, will have that retroactive coverage reduced from 3 months to 2 months. And then coming in July of 2027, we will be seeing monthly premiums be put into place. And these premiums will be applicable to our customers who receive Medi-Cal and they have a non-citizen status. So this is the population that will need to pay premiums to keep their coverage. The current premium amount is $30 per month. That's going to be coming into effect. And so significant financial impact for some members having to pay that to keep their coverage. And it is limited scope coverage, not full coverage, that they will have to pay a premium for. So, that may impact their ability to want to maintain that coverage if it's not going to meet their full scope of healthcare needs. And then we'll pass it over to James.
Thank you, Matt. Thank you, Allison. Appreciate it. Good morning, board members. I'm James Larkert. I'm the director for the Transitional Assistance Department for San Bernardino County. Happy Thursday. Super excited to be here today. Next slide, please. Sorry about that. I'm going to tackle a couple different areas: policy advocacy, training, member outreach, and operational readiness. Before I do so, though, Thomas has started our conversation about this long, rich history that we have with IHP as well as Riverside County. And I was thinking back, I got a beautiful 6, 8, and 10-year-old. Let me overshare just for a quick second. My 10-year-old wasn't even born yet, and we have had this long history even before she was born. So I can't remember how long we've been meeting and talking about how do we support our communities, but it's been a very long time. And also, real quick, before I tackle these 4 different items, Jared, you started the conversation about the federal shutdown and how SNAP was paused, CalFresh in California. I have to share with you, your team was amazing. They immediately reached out to San Bernardino and Riverside County and said, what can we do? How can we support you? And they did a lot of introductions with our faith-based and community-based organizations to say, hey, these are folks that are working in the food distribution space. We need to connect you to and have a conversation and making sure that they're ready. And we actually had one of your CEOs reach out, Greg, and I'm going to forget his last name. Thank you so much, sir. Reached out and was continuously reaching out. And I think that's just a beautiful illustration of this partnership, this rich partnership that we have. So back to this slide here. So I'm going to start with policy advocacy. And this is where I think we do a lot of great work coming together and figuring out how do we support our community, right? We want enrollment and retention when it comes to Medi-Cal benefits. And one of the legislative platforms that we are putting forward that we stacked hands on was how do we simplify the renewal process? Right now, it's an annual process, but with HR 1, it's going to become a semi-annual. And if you fall out of what we call the ex parte process, which is the automated process, you get a manual renewal packet in the mail that's probably a ½ inch thick. It has a lot of information. So what we have put forward is how do we simplify that? How do we make it easy for the Medi-Cal member to renew their benefits, semi-annual and annual? So what we are pitching and bringing forward is a automated link that would be sent via text message to the Medi-Cal recipient for them to be able to go through that renewal process. It's efficient, it's a great use of technology, it's a great customer experience, and it will help mitigate churn. So that is one example of the many policy advocacies, how we advocate for the simplification to making sure that our Medi-Cal folks enroll and retain benefits. Outreach, talk about the federal shutdown, Jared. It gave us a great opportunity of really making sure that we lean in and figure out how do we outreach to the community. And we have a lot of different ways that we do so. We have customer-facing dashboards in all of our lobbies. We have text messaging. We have outbound IVR. We have social media presence. We have press releases. We have a wealth of ways that we can outreach to the community to making sure leading up to HR 1 that they are aware of what changes are happening and that they are prepared for it. Same thing goes for training. I've been blessed to be with the county now for 29 years. We are used to change, right? That's one of the constant things that we have to kind of grapple with in self-sufficiency is that there's always change. It just depends on the scale of that change, right? Sometimes it's small change, and sometimes we have large-scale change. HR1, that's a large-scale change. So we go through a lot of different exercises to ensure that our staff receive comprehensive training and that they're well-positioned to support our community. So I think I'm going to pause there. I think I addressed all the different areas. And now for what Thomas had shared, those very technical questions that you may have, we'll direct those right to Riverside County. So I'm going to go ahead and pause.
Thank you. Thank you so much. I did have a question on if we can maybe get that slide too, that'd be great, maybe sent to us. But in terms of like the details of like, for example, the property limits, what would be the limit? Does it depend on how many folks are in a house? Is it just, okay, houses over 500,000?
Yeah, they're based on an individual. So the limit for one individual is $130,000. And then it increases by $65,000 for each additional family member.
And is it, when you say limit, is it like equity? So it's if they have they have to have less than 135,000 equity?
Yes, so there's some property that is exempt, like a primary residence is exempt.
Oh,
and things
okay.
like that. So it's all non-exempt property, which would be, funds and bank accounts and things like that. But there are some items that are exempt, and one of those is a primary residence.
Oh, okay, that's good news. That's good news, because I was a little worried that, sometimes you have seniors that, are living, let's say, in a manufactured home, and that's their primary residence, and they need the assistance, so. So primary residence is good. So what about, how would you guys monitor the work requirement, is it 6 months continuous? Is that something that you guys agree on with the two counties, or is it or everybody does their own?
You want to take that one, James?
Yeah, I'm going to try my best.
I was just curious.
It's been a minute since I've actually done the work, but our understanding, and again, we have yet to receive official federal guidance on this.
Yeah.
And once we do, our state partner, Department of Healthcare Services, would definitely digest that guidance and give the 58 counties guidance on how we're going to do that implementation. But it is our understanding at this point that requirement needs to be met the month before application and the month before the renewal is due. So that's how we're going to be monitoring and tracking that work requirement.
And the reason I ask, because you know how sometimes some folks may have a specific, like maybe they worked 3 months, got laid off, and then 2 months. I was just wondering if you guys would have flexibility.
Yeah, and again, that official guidance is still pending
Still
from
pending, okay.
our federal partners. But again, it is our understanding at this point, it is a month prior to application and the month prior to their renewal that work requirement must be met.
And then once we get DHCS to give us guidance, right?
Yes, sir.
Okay, perfect.
Yes, sir.
Okay, I think we have some questions.
Is this on?
Yeah,
No.
Yes, go ahead, Member Armanduras. And they turn it on automatic.
Oh, they do. So my question is, you know, we're having this whole thing revamped and requiring people. What are we doing with, like, is this going to affect people who have mental health issues? You know, our you know, family members who may be dealing with mental health issues, if they're, you know, in a mental health facility and they come out and obviously they can't work. How's that going to be taken care of?
Yeah.
Well, that's a
And
good one.
Thank you for that question, Supervisor. One of the guardrails here with HR1 is that there are exemptions to meeting the work requirements. Having a disability is one of those exemptions. So if you're disabled, the work requirements you do not need to meet.
What about the constant having to renew every?
I'm going to turn that to Matt, because I believe that the semi-annual renewal process is exempt also from that population. But Matt, I don't know if you're able to tackle that.
Yeah, so we are still waiting to get clearer guidance on what those exemptions are. We do anticipate some exemptions to the work requirements and also the more frequent redeterminations. We anticipate we will likely see exemptions for our disabled population, but we don't have that guidance clearly yet from the state, so we can't speak to for sure's in that area, but we do anticipate some exemptions.
So where I worry is if it doesn't come and they don't have automatic renewals with this population, that falls on the burden of our hospitals because they're going to have to treat them regardless, but now they're being treated uninsured.
Yes, and also to clarify, the automated renewal process is going to continue, and that's the first step in the redetermination process. So everybody, the system attempts an automated renewal for everybody that is on Medi-Cal. And if the various systems that our systems check with can verify information, then that renewal goes through what we call the happy path, and it automatically processes with no action needed from the member or the county. And then anything that doesn't automatically renew then has to go through the manual process. They get sent a packet, have to turn that in. And so what we do in both counties is we really try and do some pre-work to increase what we call our batch rate, which are cases that go through that automated happy path, because that's going to save time for the member and time for us in having to do a manual packet. So we'll continue to keep those efforts up in terms of keeping those automated renewal batch rates high, and hopefully most of our members will be able to go through that process.
And here may add a couple of comments on the work requirement. So even the term called work requirement, but the detail behind it include education, community volunteer hour, and work. And we are very fortunate that the DHCS invite us to be sitting on their technical work group. So I had opportunity sitting in the technical work group to help provide feedback on the policy. So a couple of policy questions that you asked, Supervisor Gutierrez, that one on the seasonal worker. So I raised that issue, and the state recognized that, and there will be a specialized policy to address the seasonal worker one. And on the work requirement and for the exception of the work requirement and the 6-month redetermination, the HCS very committed looking at automatic process. So they will look at the medical record, the diagnosis that automatically exempt those member from work requirements so the individual don't have to do anything for that. So they committed to look at all the data from the SNAP program, the CalFresh program, and any other program that already require the work requirement. So they will leverage those data and build that into the system so there will be a more automatic process in implementing the HR1.
And when you say they, who is that?
DHCS, Department of Healthcare Services.
Oh, DHCS.
DHCS,
Okay.
yes.
And but isn't it the individual counties that determine or the eligibility?
And yeah, you're right. At the county level, the county will review and approve. But at the state level, the state managing the whole council system, correct me if I'm wrong, that they managing the whole eligibility data system. So they able to download those data
For the automatic
into
process.
the system. So to support the county, so the county have some data already there to review and approve versus, chasing, one by one
big
to the
packets.
medical member.
Yeah.
Correct.
Got it. Okay, wow. Okay, yeah, and Member Zorn?
I had one deep dive question and one broader question. So Allison, the first one I had was for you related to what you were referencing with emergency services. What would be covered there? Are we talking urgent care? Are we talking ER, trauma? What does that look like?
So the reduction in benefit coverage for the undocumented population
Yeah.
would cover emergency services such as the ER.
So just the ER?
Yes, these would
Okay.
be things outside of regular visits.
Yeah.
And then pregnancy-related services would also be included.
Okay, that was going to be my next question attached to that, so I appreciate that.
So preventative care, things of that nature will not be covered in.
None of that.
No
So
vaccines?
Those are not covered. I do not believe those are covered under emergency. But these are for adults 19
Yeah.
and over. So children 19 and under will get the full Medi-Cal. So younger will still get
But my
vaccines.
understanding, and correct me if I'm wrong, I believe state law requires each county to have a medically indigent, let me see if I get it right, indigent services program, and I believe Riverside County has one because we're required. So those folks would have to apply to that, and then they could be able to get preventative care. I don't know.
Yes, there are a few small populations that we can exempt from the undocumented group. And so we do look to see if we can fit them in so that they can get that coverage.
Okay.
All
The
right.
miss-
Second thing, I am amazed at how well you got this coordinated to date with such a short amount of time. It just speaks to your ability to pivot incredibly, so kudos to you on that. Then the broader brush piece regarding communication and all, it seems like getting the word out as to what is truth and what is fiction has become such a high concern item. How is that going? What are the parts that are just not working well right now? How can we help? How's the partnership going? Just a broader brush.
I can add a piece for Riverside County. We spend a significant amount of time really looking at how do we educate the communities through various partners.
Yeah.
IEHP is one of them.
Yeah.
And we look at managed healthcare plans, many of our community-based, faith-based organizations, and we do a great amount of community outreach. We have mobile units, so we're out in the communities making sure that that education is happening at that level of our customers.
Yeah.
James had mentioned just the amount of training that we will also have for staff, and then the technology that we leverage. So whether it's through our social media, regular media, we have robocalling, text messaging, and just really how do we saturate this population with information. So those are some of the ways in which we're doing that now, but definitely, the partnership we have with IEHP is instrumental in being able to reach
Primary partnership.
Absolutely.
Yeah.
Yes. I don't know if there's anything.
No, I think you covered it nicely. Matt touched on this a little bit, is that we're still waiting on that federal guidance.
Yeah.
So once we get that federal guidance and then DHCS is able to digest it, and then they can get the 58 counties that guidance, because we always row in that same direction and making sure that we complement the state's messaging. And that's where that hard work comes into play, and really outreaching to our community partners and reaching out to other southern counties to share how are we going to be getting that message out to our communities.
Appreciate that. And last thing is, how are you managing the impact on staff, too? Because
Great question. That change management piece is critical, right? And both of our counties, we believe in communication and really making sure that we get ahead of it, right? We want to make sure that we control that narrative and that messaging with our staff. So the more proactive we are getting messages from our leadership to the staff that are going to be responsible for that, that way we can mitigate your earlier comment about the misinformation that gets out there.
I guess I have a more technical question in terms of eligibility technicians, at least for Riverside County, because I'm Riverside County, but are you planning to, because this rolls out January, right?
2027.
Oh, 2020. Okay, so we got a year.
Some changes effective January 1st, 2026.
Okay.
Those larger scale HR1 related changes, most of them are January 1st, 2027.
So is there modeling, or how do you figure that out to determine, do we need to hire more people to do these things?
So at this time, we are already seeing an increase in workload, as I mentioned, like having to come out of an automated process into more manual. Unfortunately, we did not receive any funding this year with that. So we are not adding any eligibility technicians. We hire just what we attrition out.
And there's still a shortage, right?
Yes. So in 2027, at this time, we have not received any information about additional funding for staffing either. So we are trying to be proactive in looking at ways to streamline processes. The education of the community is a big part of that, in being able to prepare them so that they are turning in that verifications and doing that work. But at this time, we do not anticipate receiving any additional funding.
Okay.
And just to quickly piggyback off that, both of the counties are eligibility staff that are trained in Medi-Cal are also trained in CalFresh. So there is a requirement that they're trained in both of those programs. So we have that flexibility to move and shift staff depending on the workload. And Supervisor Armendariz, just for San Bernardino County and what we do to kind of ramp up the hiring, we do anticipate that increased workload. So we hire staff every January, May, and August of each year. We always go with our fiscal team and kind of understand what those numbers look like and how many we can hire. Similar to Riverside, we absolutely hire what we attrit, but we also look at how many folks we can kind of maximize and ensure that we draw down 100% of that Medi-Cal admin funding.
Are we utilizing technology also? Are we looking at how we can implement stuff like AI and systems that'll make this a lot more streamlined?
Yeah, wonderful question. And I think that goes to one of my earlier points about how do we simplify it for the recipient, but also with that text message link that would definitely help make things more efficient for the staff. And then we're always also looking at our call centers. Both of the counties have call centers, so looking in and leaning into how do we introduce technology there to support our call center agents. There's great work at the CalSolace project and other counties of looking at how do we fold in that AI technology to help support the customer and to help support the staff and make things more efficient. So to your question, yes, sir, we're always looking to see how do we make things more efficient for staff, and absolutely how do we make things more efficient and streamlined for the customer.
Okay.
If I can also add one point to that. We also advocate a lot for automation in our system. And so whenever these changes can be automated, it really minimizes that staff impact and minimizes how long it takes them to process an application, process a redetermination, and then their capacity just grows. And so we are strong advocates of that. We have staff in both counties that are part of work groups and committees that discuss how to get these changes into the system. And we are strong advocates for whatever we can do to automate those changes and really reduce manual processes for our staff and have them work more efficiently.
Okay. I think we have a question from Member Zorn.
Just one last quickie. One of the things that are near and dear to my heart is the foster care system and foster kids, because they're such a vulnerable population. Are there any special concerns with them or any thoughts, as far as you're concerned, that you see them as, would they somehow be exempt?
So at this time, because they are under 19,
Yeah.
they are exempt. That is a little different for our non-minor dependents as they age out.
Thank you.
Then yes, they fall into the population. We are seeking clarification on what does that mean for them paying premiums.
Yeah, yeah.
What is that? And a lot of unknowns still at this time. As we mentioned, the Department of Healthcare Services is still pending responses to many of those questions for that population specifically.
And I have to say, Allison, I'm very appreciative that you have this in your awareness, the kids, especially those that are a bit older, that often it's them that fall through the cracks. They're not seen. Nobody really pays attention on those. So thank you.
Thank you.
Okay. Thank you. All right. Seeing there's, yes, Member.
Yeah, just from your perspective, I imagine this will be, this is going to be challenging, of course. We know any changes will drop people off the roll, especially the population that we're working with. This is probably scary for them, but I would imagine the hospitals are quite concerned, knowing that these kind of changes will cause people not to be insured. And I just want to bring the point up that these are challenging times, and I know you guys are going to do your very best, and the mandates aren't coming from you, they're coming from another source, and I think we understand why these changes are put in place, but what it'll do to this population is going to be devastating, probably, but best to you in your work on this. But I would imagine somewhat, you guys have had conversations where this can be scary as well.
Mm-hmm. And I would add, thank you, Mr. Anderson, is that we do have a presence, and I know San Bernardino does as well, in our county hospitals. We have staff in our healthcare centers so that we can meet the customer while they're there seeking services to either enroll them in the Medi-Cal program and or to assess whether they have those upcoming renewals so that we can get those from them and help them while we see them. So both counties already trying to kind of embed ourselves into the healthcare setting.
Yeah,
So.
but we've had these challenges of uninsured for a billion years, and this isn't steps forward in terms of helping the uninsured. So Medi-Cal population will have to struggle through, but thank you for your help.
Okay. Thank you. Any further questions? Seeing none? Okay, thank you, guys. Appreciate it.
May I end the presentation with 3 shout-outs. So first one, I would like to recognize Shalong Jones, our Director of Eligibility. She worked across the organization. She couldn't make it today. She worked with provider services, member services across the organization to bring all this together. And second, highly recognize our 2 counties. Through the last PHE redetermination, our 2 counties have one of the highest renew rate at 85%, way higher than any other county of the state. Third, that a couple months ago, you may heard about CMS sending a list to our state, all the state across the nation, that with a list of members who they believe that erroneously enroll in Medicaid program. Our San Bernardino County received a list of 3 members. And Riverside County received a list of a very handful. So I'm very confident in the execution and implementation of the policy, how effectively and how efficiently at our 2 counties. So I would like to give that shout out to our county partner. Okay. Thank you very much.
Thank you, sir. We're going to go ahead and move on. Or did you have anything?
more?
No, I was just going to continue my report. But
okay,
if
go
you'd
ahead.
like me to not, I can
Go
stop.
ahead.
Okay.
You're done.
That's okay. Well, again, I really appreciate the two counties. Thank you so much for all that you do for our community. It's an unprecedented partnership for sure in our state. All right, going to speed through this. I know we're needing to make up some time here. So lots of action happening in the news, a tremendous amount of advocacy work on HR 1 and the effects that it's going to have. You heard about that already, of course, and just very, very pleased with so much of the work that's being actually taken up and picked up by press and media to share the concerns that we have. We still do not have resolution on the enhanced premium tax credits. You will see a significant change in membership come January 1st unless Congress can get that figured out. And so you'll just note that it's going to impact tens of thousands of people in our two counties, hundreds of thousands across the state, and millions in the United States. So it's just something to be aware of and know. On our provider dinner series, of course, they keep moving right along and just going great. On the next slide, some great feedback from those folks, again, mostly on HR 1 and the DOJ issues and CAP surveys and whatnot. And so just really appreciate the feedback there. On the next slide, we had a really great visit out in the Coachella Valley with Dr. Amy Young. Some of you probably know Dr. Young. She does incredible work with the Resiliency Institute for Childhood Adversity. Absolutely one of its kind in the United States, where we now have more fellows going through this program here in our two-county region than in any other part of the United States. And I'm so proud of her work. They're looking at a new site there in the Coachella Valley to continue that work for child abuse pediatric program. It's one of those programs that is so heartbreaking that we have to have that as a society. But at the same time, I'm so grateful that we have this team that is so committed to this work. Just incredible. On the next slide, we hosted a healthcare project management summit. Really appreciate Thomas and the team for leading that. Some really, really good bringing forward best practices for project management. On the next slide, I was invited to go over to CUSM the other day to speak to their medical school students and had just a fantastic time with that group there on that campus and really pleased with the work that they're doing on ARMC's campus. And then also on the next slide, we had our healthcare scholarship Scholars Dinner, and we hosted it right here at IHP. And boy, we had a good showing of healthcare scholars. These are medical students, residents, and their families came to support them. We do this once a year, as you know, and we're just so thrilled that they could join us and be with us. And then finally, I'll just share with you, I'm really grateful to the True Evolution team for this Defender of Health Justice Award that is going to be coming here. And this is really for the entire team. They put my picture on it, but it's really for IHP and for everybody here at IHP. And so I just wanted to say a huge thank you to that. With that, that concludes my report, Mr. Chair, and we can move right into our board education, which will just take a couple of minutes if you're okay with that.
Okay, perfect.
I just have something real quick. I love all the pictures. You see how I always lean in? On your membership list, you keep using the same pictures. I like different ones.
Okay, on the membership one?
Of the doctor holding the two kids, nobody noticed that's the same one?
Okay.
Thank you, Susie.
Well, we can change it up.
It just kind of
It
gives.
is one of our doctors,
I know.
but we can change it up. we'll make sure to change.
I just love to see the picture. It just kind
Yeah.
of gets us a little more connected.
Yeah, that's a great idea. We'll make sure to get you some of the latest. We have a lot, so we can
I know
absolutely
you do.
that
That's
for
why
you.
I said change them.
We'll do it. We're going to change them. You got it. Well, I'm going to invite Kirk Furman to come up and quickly go through the Timely Access program, just so you're aware of that. And Kirk is one of our incredible leaders who makes sure that our network meets the standards for what the state and the federal government requires of us. Kirk, take it away, man.
All right, thank you. Good morning, everyone. All right, we're talking about timely access, but I did want to kick the presentation off really quick with network adequacy. We can go ahead and advance the slide. So network adequacy, timely access, very closely related concepts when we talk about our provider network, but they do focus on different aspects when we're talking about access to care. So typically when I'm here, we're addressing things regarding network adequacy, and we assess network adequacy. One of the ways is through our physician to member ratios. So our workforce, basically of physicians against the population that we're serving. Let's go ahead and advance to the next slide. Another way that we assess network adequacy is based off of the geographic distribution. We have a great informatics team here at IEHP that gives us these visual representations on how far members have to travel to be able to access care, and you can see the breakdown on how we maintain oversight for this across different specialties. So when we talk about timely access, this is now getting into that point where we have a network in place. The workforce of the bodies or physicians are there, but how quickly can members secure appointments with those providers? So we have a provider network access subcommittee that looks at various annual studies to see how we're performing in that space. One of the first ones I'd like to call out on the next slide is going to be our provider appointment availability study. There is an annual survey that we conduct to see how the different provider types are performing. So up there on the table, you can see the prescribed appointment times that members should be able to secure, whether it's a routine or urgent appointment, also depending on the type of appointment by provider specialty. So we do contract with a third-party vendor that'll reach out to our network via fax, email, or phone to see basically if they're meeting these standards. One of the more stringent requirements we have right now, DMHC requires a goal of 80% compliance for appointment availability. But IEHP currently sets a standard of 90%. That's our stretch goal of meeting a 90% compliance rate. Apart from securing their appointment, so if you imagine a member secures their appointment, another study we look at on the next slide is our provider office wait times. So once they've secured their appointment and they're, yes.
Can you go back to the last slide just for a second? On this one, do we have metrics and graphics as to how well we're doing on all of these? You know, on the things that you're saying here, IEHP sets a target goal of meeting 90%. Do we have a regular?
Yes, in the study, we can supply that study. It's the provider appointment availability study.
Just
and there
wondering
are,
how we're doing.
we're improving. In some areas, yeah, for the routine appointments, we're doing better. But the urgent appointments is where we're experiencing some of the challenges.
Which ones? I'm sorry.
For urgent appointments.
Urgent, yeah,
Yes.
getting them in quick.
So recently, we saw rates were declining year after year when we reviewed the study. So there was a what we called a problem solvers task force that was put together to specifically address this, which we worked on throughout 2025. And when we completed the 2025 study, not hitting all the benchmarks we want yet, but we did see substantial improvements in all areas.
Maybe at some point in time, we can invite you to come back when you have the information. We have more time to just understand it better so we can lean in with this.
Yes,
with you.
absolutely. I believe for this month, we did include a assessment of network adequacy as part of the agenda. It looks at all the studies, but it takes like little chunks out of each one. But we could do a specific like focus review on any of those that you'd be interested in.
That'd be great. Thank you so much. Appreciate
Great.
that.
So for the provider office wait times, members secure their appointments. We're also taking a look at how long they're waiting in the office to get care from the providers. We do field data from this in 3 ways. We do have a semi-annual provider directory verification that we conduct, and the providers are able to identify for us how long members are waiting. We do have a pretty good compliance rate for this too, where scheduled appointments are being seen under the 60 minutes. They'll identify that, as you can see on the slide, though, there's different bracketings on, whether they're seeing members typically within 0 to 30 minutes, 31 to 60, and so forth. We also gather data through our facility site reviews, and then also when our field reps or our provider relations managers are out for focused in-service visits, they collect that data as well. And this measure here has a 90% or a target of meeting a 90% compliance rate, which we're meeting.
Great.
Now moving on to after hours on the next slide. So we also maintain oversight on how members are able to access care outside standard business hours. We have the after hours access study for this, which we monitor the availability of an after hours on-call physician. So basically either after hours, they're being connected to a physician, the on-call physician or recovering nurse, or they're being provided with the instructions on how they can do that. Same goes for the life-threatening emergencies. We're always making sure that the call handling protocols after hours, for instance, if it's an emergency, they dial 911 or go to the nearest emergency room. And then also on the member satisfaction survey, we're surveying the members on how often was it easy to get the after-hours care you thought you needed, and also when you needed after-hours care, what did you do? So some of the things that we're paying attention to, and then the last one for us ties into after-hours access. Let's go ahead and advance to the next slide. Our nurse advice line. So ensuring that members have access to care 24 hours a day, 7 days a week. This is through our vendor CareNet for nurse advice line. But we're reviewing this through an annual study as well, that they're getting that proper triage and screening. And then 3 of the metrics that we look at closely is how fast members are able to get care through the nurse advice line. So the speed of answer, what % of the calls are answered within that 30 seconds, and then also the call abandonment rate, where the member basically hangs up after dialing in. So all of these things, the timely access space is, we're trying to occupy this space a lot more. Going back to network adequacy, we've seen a lot of improvements. Typically when we come here and we present on the Network Expansion Fund program or the Healthcare Scholarship Program, those immediately impact network adequacy. We put that body there, ratios come down, geographic distribution looks a lot better. We saw in some of our recent studies, some of the specialty ratios move from non-compliant to compliant. So now we're really trying to focus on how do they access these appointments sooner. And that's the areas we're going to be focusing on. I called out earlier, DMHC's goal for us is 80%. DHCS is going to be raising the minimum performance levels year after year. They're currently at 70%, but by 2027, they expect us to be at 80%, and then the following year at 90%. So we're definitely going to be doing a lot more work in timely access.
And it would be great, again, when you come back and share with us a little bit where we have biggest opportunities and how we can lean in with you on
Absolutely.
those. That'd be great.
Great. Okay, thank you. Thank you, sir. Okay. All right, we're going to move straight into our finance department. And there's 2 items on this one. One is the monthly financial review, and the other one is to adopt and approve the IEHP interim calendar, operational and capital budget as well. So we'll go ahead and start with Tim for the first.
Thank you for the opportunity to address the board. Next slide, please. I'm going to try to move through this relatively quickly, but please stop me if you have questions.
Thank you.
So our financial statements as of September are up on the board and in your packet. The September profitability is down, which is disappointing, though the year-to-date remains positive at just about $7 million. I have to say, though, that the statements are so close to break even now. We're going to see some volatility in the next few months, but I think it also reflects the positive work that's been done from 2024, where there were substantial deficits. So we've made a pretty significant improvement, and we'll talk about it briefly in the budget process, but we anticipate next year will be more about building up our reserves back to levels more similar to what they were in the past. So our budget and our results today aren't really where we want them to be, but they do signify a big change, and so that's a positive. And in terms of next year, I'll just preview here. We just received today a set of rates for 2026 in some detail, which is why the budget you're going to see today is only preliminary, because we didn't really know what our revenue was going to be for the coming year. So we're going to incorporate that in our budget forecast for next year, but very positive. We were able to secure quite a bit more revenue than we originally anticipated, and I might add more than other plans received. So, so that should help us meet our goals next year. Next slide. So this is a chart that you see monthly. You can see that the blue line is significantly better than the prior line, but it is bouncing around the break-even point. So again, we're going to seek to make that go up from that period, but as you can also see from the orange line there, significantly better than last year. Okay, could you move ahead to 12? Skipping a few slides here along the way. I was going to talk about that. You can see we made positive results there as well. You can see 2025 has really stabilized from the increases we'd seen before.
Is this slide 12 or?
And the next slide. Yeah. No, it's okay. I want to do the T&E and could I see 11? I'm sorry, I can't read my own writing of what side I want to. So Carol had to correct me. That's what you have an actuary for, so she knows the numbers. So you can see our tangible net equity, again, which is our reserve levels, and we are still significantly above the required reserves, and they're relatively stable. Our cash on hand, again, is just like the bottom line. Profitability is bouncing around. We definitely need to improve on that, and we have a number of initiatives which we hope will positively affect that. But ultimately, if profitability is what we hope it is next year, cash on hand will follow along with that and will improve a fair amount. Okay, well, if you have any questions, I can answer them, or...
No? Any questions? No? Okay. Thank you, Tim. We'll move straight to 32, which is adopt and approve. Were you going to do a presentation on that one?
Yes.
Oh, okay.
So I just kind of want to remind everybody that, and I just mentioned it a minute ago, that this is a preliminary budget, and we certainly need it passed, so we have spending authority for next year, starting in January. But we didn't have all of the revenue figures, so we brought this preliminary budget forward and want to let you know basically where we're starting from, and then we'll update it with the revenue. And we will also update it with additional changes to our costs, both administrative and healthcare, as we develop more information. One of the areas is we have a number of initiatives we're doing now to be more cost effective. And even from this budget to, since we put it together, we're going to lower some areas $12 million from what's in the budget here. And so we're going to look for other opportunities. But as I mentioned, the biggest impact is going to be the change in the Medi-Cal rates, because we have I'm pausing for a minute because it's kind of funny there. We have the prospective final rates, which DHCS is required to give to us before the contract year starts by state statute and CMS, I guess probably regulations as well. But they plan on maybe changing them later. So they call these the final prospective rates, so they can technically meet the prospective requirement. So there is some uncertainty, but usually that's pretty minor, whether it's positive or negative.
So what's the 12 million?
The 12 million was, I believe, a number of consulting contracts that we made adjustments to try to, really get down to what we absolutely have to make sure we hit our targets operationally and financially, as opposed to we think this is a good idea and it would be.
I think we did that before, right? To try to save money?
Right.
We've been doing that for a while, actually.
Yeah, we just went through another round, another scalpel round. So we're really, I'm line item vetoing is what I'm calling it, just taking stuff out. So yes.
This is major surgery in clinical terms.
It's major surgery, yes.
But the good news is that we're going to get more money with the new rates, and I think we did receive that email as well a few days ago.
Yes.
From Jared.
So that's encouraging. And again, overall, it should allow us to start to build our reserves back up and our cash on hands back up to what we would view as more appropriate levels. It's too volatile to be that close to break even all the time because there's just a certain variability in healthcare.
And if I read correctly, was it 200 million extra we're going to get, or 250?
Approximately. The team has to do their the team has to do their
That's pretty good. That's
the
really
team has
good.
to do their work,
breathe.
but big kudos for the advocacy on the state to share the story, which is what Carol and her team do to make sure the state's adequately paying for our experience. And so, yeah, they've done a great job.
No, thank you for the advocacy.
Yeah, and on that level, for Carol and her team and others here really have helped do a turnaround, and that's really been from all the departments working. But the finance team here in the Empire, I can say, because I didn't put them together, so it's not to my credit, but really has done a good job of providing data to the state to push them on their rate process.
Nice.
And this rate bump, just like last year's, is primarily because of Inland Empire. And some of it helped all the other plans as well, but we provided much more data and pushed much harder on the department about issues that we saw were, inadequate in terms of their funding. So I think that certainly is Carol and her team and others as well.
And I would just say, I really appreciate you helping us recognize where some of that heavy lifting has been coming from and the effort that goes into making that happen. Yeah, thank you, Carol.
Yeah, the state doesn't naturally want to overpay you, certainly. And so sometimes they overcorrect and underpay you. So they need encouragement. Vicki, do you want to touch base? So we're in the budget now.
Okay, yeah. Do you want me to go through the slides that we discussed then?
Yes, so I think we should try to move quickly if
Okay.
we can.
All right, next slide. Okay, as you can see here, we have our 26 income statement that we have. We, again, preliminary. We actually anticipated about a $31 million surplus for 2026. Again, we know that the new rates coming in is going to adjust that significantly. So that's a
250 million
plus.
extra.
Yes.
Yeah.
We do hope to see that the Medi-Cal, line of business will actually improve as well, obviously. Okay, next slide.
So I had asked for this one to be included, just so you can see the growth on both the revenue and the costs over time, but how administrative costs basically have remained relatively flat over the last couple of years. So again, that's, some of the work we've been alluding to here. But the revenue is growing pretty fast, as well as our healthcare expensive. But that revenue growth you see up there is abnormal. You don't normally see that much increase from year to year. And there's been a lot of program developments within Medi-Cal that are driving this, as well as the aforementioned discussion with the state about adjusting our rates. But hopefully we'll continue that trend, but I'm not fully confident of that. Unfortunately, our budgets are affected when the state's budget becomes tight, and this certainly might be a tighter year for everybody that's involved in this. Go ahead, Vicki.
Okay. So again, all this information that you're seeing here today, when we're looking at our budget, will be updated once the new rates we've finalized and gone through and analyzed them. So we'll increase that for the next presentation as well. Next slide. Carol, did you want to discuss membership? We're doing a tag team here.
Yeah, because Leona is out sick, so. I'll go through this real quick because a lot of them, membership projection, I think is probably going to remain pretty stable kind of as we project the major changes that are coming in. We went through that in the finance committee with the team. That's what the major change, I think the team earlier kind of mentioned about the Medi-Cal side, the freezing of the UIS populations, and that mainly is driven by, that drive the net loss that we are projecting for 2026. D-SNP line of business, we also expect some, decrease of the membership because of the benefits kind of decreasing due to that VBIT program, the value-based insurance design program that going away, as well as kind of lower star rating for our plan. So, and Cover California line of business, we also anticipate a drop, which is relatively large because of the expiration of the enhanced tax credits. We do expect the whole market's going to contract. Members are not having enough money to pay for the coverage, so they naturally going to drop the coverage. As kind of Jared mentioned, the recent bill that Congress went through didn't quite address the extension of the current expiration of the enhanced credit. So I think the next round, there might be still a chance they're going to bring back in December, but as of the current legislature, it's going to expire by end of the year if no action is being taken. So we do expect that we are ending 2026 at 1.4 million membership. That probably, I think, when we come back with the next round of, updated version, I think the membership probably relatively the same as what we expect. Next slide.
Yeah, we can talk about it, yeah.
Oh,
Okay, so for this one here, we actually wanted to share with the board that when we were actually looking at our rates, we wanted to compare what we're actually running as far as our administrative load compared to our rates. We actually provide you what our actual rates are, what we're budgeting, and actually what DHCS is actually providing us our rates. So you can see that we've typically, we budget a little bit higher, but we've always ran below, for the most part, under. Next slide, please. Again, as we've experienced some of the losses that we've had over the last year, and we want to make sure that we're doing things more efficiently and using a lot more automation. Directive that was given to us from our executive leaders that we wanted to actually reevaluate the headcount that we currently have. And as you can see that in the beginning of January, we had over 4,000 FTEs, and through basic attrition, we've actually been able to reduce that significantly. We still have some areas that we know that we're still evaluating, but overall there is no layoffs or anything like that. We're just looking through natural attrition and seeing how we can better automate things and use innovation. Next slide, please. Again, this is just a really pretty picture, so you guys can see where everybody is. As you can tell, a majority of our FTEs are on our front line, our operations, our call centers, and our health services that are actually there to take care of our members. Next slide.
Quickie question
Yes,
on that
ma'am.
one. Has that changed the dynamics of this, of the distribution over time? Just curious.
Not really.
Not really?
As we're
Okay.
seeing, it's really across the organization wide. So it's no one area has been hit harder or less than the other. So it really has been pretty much even across the board. Mhm. Thank you. Next slide. Tim, you want me to take this one?
Well, I'll try to speed up here. Stop me if I start talking a lot. So this is a chart we've shown you before, which is comparing the revenue and administrative costs and the percentage each plan's of their revenue that is spent on administration. And you can see IEHP there in blue is at 5.9%, which is a target of, we were trying to set for this year to keep under 6, so looks like we're going to achieve that. All the plans, though, you can see have relatively low administrative expenses. I will say, though, that it's really hard to make comparisons because some of these plans, like LA Care there, where I used to be the CFO, has a lot of delegations. So its administrative costs aren't really reflected in its own budget because they're actually in its delegates' budget. Other health plans, medical groups, that have to process claims and all those things. So it's not really apples to oranges, but I think, keeping your administrative costs under 6% is really an accomplishment.
Great.
Next slide.
Okay, and then the last slide, well, there's one other after this, but the other area that we wanted to get board approval on is to move forward with our capital budget. This budget, as you can see, that it's right around $34 million. So that would actually put us kind of really close to a very slim margin afterwards. These have been cut significantly from our IT perspective and even from our facility side. They're basically putting through there what are our absolute necessary items. There's no real wish list in here. A lot of the things that it's actually forced us to move out a couple years and actually budget even for 27, 28 and what that roadmap looks like. And with our last slide, we have our cash on hand.
Well, I already touched on that earlier, but you can see the projection for the coming year doesn't have it growing significantly, and or improving significantly. And that's, again, because this projection has us basically with a very small profitability level. We're anticipating once we update it with our final prospective rates that this will improve along with our profitability.
Okay,
Great news.
Thank you so much. I really appreciate the presentation. And the good news is we're getting that 250, so that'll help us a lot. So that's great. Great. So it's a big bonus there.
Don't spend it yet.
I know, right? That's right. That's right. Okay, so this one does require an action, so I would like to ask for a motion to approve the IEHP interim calendar year 2026 operational and capital budget.
So moved.
Motion made by Member Zorn.
Second.
Second made by Member Anderson. All those in favor say aye.
Aye.
Okay, aye. Okay. All right. So that motion carries, and there's no comments on that. So we'll move straight to comments from the public on matters not on the agenda, Madam Clerk.
I do see a hand raised in the audience, Chair.
Okay, yes, go ahead, sir. Oh, here, come right over here. Yeah, you can read it from your phone, but just use the podium, and then you have 3 minutes.
Sure, thank you. I would like to...
oh, sir.
Yes, the point number 23.
Okay.
I'd like to give my feedback because whatever been said by the one of your team member wasn't right.
Okay.
In fact,
well, and it's comments on go ahead.
Okay,
Yeah,
thank you for the opportunity. I would like to object to what was said about the feedback loop by Mr. Mike, that was never provided to us or the transportation provider. I strongly urge that board to make a deeper look into the RFP, as it has been mired in irregulations. Transport providers and IEHP members have been severely impacted over the past few years, and on behalf of dozens of providers and your members, I hope that board does not take this request for further vigilance lightly. I encourage you to speak with your internal teams as well, beyond Mr. Mike Grant. My final concern is that A3 was hired to assist with this process at a cost of nearly $500,000, as disclosed in the last board meeting. I would like the board to examine the potential conflict of interest, given that A3 consultants are former colleagues of executives at MediDrive. The entity awarded this RFP even though they failed the integrations. That will be all from my side, and thank you very much for the opportunity to say that. I have this in my earlier 3 questions that's never been answered. Can I hand over this to
could you hand that over to our clerk, please?
And Chairman, for the record, the public speaker was again S. Wakar Naqvi.
Yes.
Thank you.
Thank you, sir. Thank you, sir. Thank you. Okay, board member comments. Okay. Seeing none, we do have 2 closed session items today on today's agenda. As there will be nothing to report afterward, we will adjourn this meeting to Monday, December 8, 2025 at the Mission Inn in Riverside. Madam Clerk, will you please read the closed session description into the record, please?
Yes, sir, thank you. With respect to every item of business to be discussed in closed session pursuant to California Government Code Section 54957B1, Public Employee Performance Evaluation, Chief Executive Officer, Inland Empire Health Plan. The second item with respect to every item of business to be discussed in closed session pursuant to California Government Code, Section 54957.6, conference with labor negotiator, agency negotiator Supriya Saad, Chief People Officer regarding unrepresented employee, Chief Executive Officer.
Thank you. And we'll go ahead and move into closed session. Thank you, everyone.
We're adjourned.
And adjourned.